Good morning, everyone. Okay, so today we will start with the internal structure of duodenum, which was left in the last class, followed by the gross anatomy of pancreas. Now, in the last class, we have discussed about the almost every aspect of the duodenum. Okay, that is the first part of the small intestine. Okay, today we will see the internal structure or interior of the duodenum. Okay, now here you can see the diagram showing the interior of the duodenum. Okay, now what exactly is present inside the interior of the duodenum, that we have to know. Okay, what are the mucosal folding, what is the pattern of the mucosal folding, along with that what are the other important structures, that also we have to study. Now, if you see the internal structure of the duodenum, okay, if you have studied the internal structure of the stomach, you can correlate. Now, in the internal structure of the stomach, do you remember you have studied about the gastric rugae? Now, if you have studied the internal structure of the stomach, you have noticed that the mucosa of the interior of the stomach is thrown into folds, irregular folds. These are called as gastric rugae. Right? Now, similarly, in case of duodenum, first part of the duodenum, if you see the mucosa, okay, it is not irregular. There are regularly arranged circular folds, okay, which are present in the duodenum. Just after the first few centimeters of the first part of the duodenum, these circular folds are present, and these are called as valves of Kerkring or plica circularis. Okay. Now, if you see the diagram carefully, so this is the interior of the duodenum. Okay, now in the interior of the duodenum, you can see these are the circular folds. Okay, these are the circular folds. Now, first few centimeters of the first part of the duodenum, okay, few centimeters of the first part of the duodenum, these circular folds are absent. Beyond that, you can see the circular folds are present. Okay, now these are permanent folds. Okay, these are permanent folds. Why these are permanent? Because these particular folds are formed by mucosa as well as submucosa. Okay, that's why these folds are permanent in nature. Okay, as you can see. And what are these folds? These folds are also called as valves of Kerkring or plica circularis. Next, now the question is, why these folds are present? The folds which you can see over here, the circular folds, okay, why these are present? Any idea?
Access denied.
Because we know that in case of duodenum, the most important function is, first of all, digestion will get completed, and after that the absorption starts. Okay, now for doing that, if the food which is coming from the stomach, if it is passing very fast, at that time there will be very less time for the duodenum for absorption. Okay, that's why these folds are given, so that the food which is passing or traveling through the duodenum, okay, it will be slower down. That means the food will pass through the duodenum, but it will slow down. As a result, the time will be there to do the absorption. Okay, that's why these particular folds are there. Okay, next, inside the second part of the duodenum, especially, okay, inside the second part of the duodenum, you can see two openings are there. The upper one is called minor duodenal papilla, lower one is called as major duodenal papilla. Okay, as you can see, this is the minor duodenal papilla, this is the major duodenal papilla. Okay, now what are opening in those two papilla? In case of minor duodenal papilla, as you can see, accessory pancreatic duct is opening, and in case of major duodenal papilla, main pancreatic duct and the common bile duct. Okay, they will join together just before the termination to form hepatopancreatic ampulla or ampulla of Vater, and then they will terminate into the major duodenal papilla. Okay, so these are the two important openings present in the posterior medial wall of the second part of the duodenum. Okay, so in MCQ, those questions can be asked. Okay, how many papilla are there, which part of the duodenum, where they are situated, what is opening in those papilla. Okay. Next, if you see the circular folds, okay, now there are certain areas in the interior of the duodenum where folds are not exactly circular. Okay, there are some areas where the folds are not exactly circular. Some part it is semicircular, some part it is longitudinal. Okay, I hope you can notice. So if you see the minor and major duodenal papilla, okay, see this is the minor duodenal papilla. Above this, can you see the fold? It is semicircular. Here also, this is the major duodenal papilla. Above that, you can see the fold is semicircular. Okay. Now below the papilla, you can see the fold is longitudinal in nature. Okay. So there are some changes in the pattern of the folds, and that are associated with the major and minor duodenal papilla. Okay. Now, so these are called as a semicircular fold. You can see these are semicircular fold. Now this particular fold which is present above the major duodenal papilla, it is called as plica semicircularis. It is called as plica semicircularis, or also called as monk's hood. Okay, just like a hoodie. I hope you know how the hoodie look like. Okay, so this particular fold which is present above the major duodenal papilla, it is just like a hoodie. That's why it is called as monk's hood. Okay, here the fold is not circular, it is semicircular. Okay, that's why it is also called as plica semicircularis, or also called as monk's hood, which is semilunar fold of mucous membrane. Next, if you go below the major duodenal papilla, as you can see over here, if you go below the major duodenal papilla, then the fold, mucosal fold which is there, this is longitudinal in nature. Okay, see the fold it is longitudinal in nature. Okay, that's why it is called as plica longitudinalis. Okay, so these are some changes in the mucosal pattern around the major and minor duodenal papilla. Okay, so till now I don't think so you have studied about the duodenum. Okay, when you will study the duodenum, I will request everyone, okay, to take the LS of the duodenum, open it, and then see all those things. Okay, very important. Okay, and it can be seen easily. You don't have to use anything, no microscope, no magnifying lens, nothing. Just take the LS, open the duodenum, you can see these structures. Okay, and I will also request you to see the openings for the minor duodenal papilla and major duodenal papilla. Okay, so whatever we have, I have discussed, it's mentioned over here. Okay, so the circular folds which are present, these are called as valves of Kerkrings or plica circularis. Okay, now in the second part of the duodenum, the major duodenal papilla is there. Now if you see the major duodenal papilla, it is a well-marked conical projection where it is situated posterior medial wall, 8 to 10 centimeter distal to the pylorus of the stomach. Okay, that means the location of the major duodenal papilla, it is 8 to 10 centimeter distal to the pylorus of the stomach. Okay, now at the peak of the papilla, okay, hepatopancreatic duct or hepatopancreatic ampulla or ampulla of Vater, it is opening into the major duodenal papilla. Next, small duodenal papilla, also called as minor duodenal papilla. Now it is situated approximately 2 centimeter proximal to the major duodenal papilla. Okay, so first you will be getting the minor duodenal papilla. 2 centimeter below that you will be getting the major duodenal papilla. Okay, the first minor and then major duodenal papilla. Okay. Next, arc of plica semicircularis. This creates an arc over the major duodenal papilla, also called as monk's hood. Okay. Next, plica longitudinalis. It is a vertical tortuous fold of mucous membrane which is going downwards the major duodenal papilla. Okay, that means it is a longitudinally placed fold of mucous membrane which is extending downwards below the major duodenal papilla. Okay. Now these particular points are very important. Okay, why this is very important? Do you remember in the last week I have discussed about the extrahepatic biliary system? Now in the applied part of the extrahepatic biliary system, I have told you that there is an investigation called EHBS, ERCP. It is an investigation called ERCP, endoscopic retrograde cholangiopancreatography. Okay, where if any gallstone is there which is blocking the various part of the extrahepatic biliary system, at that time with the help of this ERCP, okay, it can be diagnosed. Okay, where and I have also mentioned how the contrast media is given and how the contrast media is flowing. Okay, so this particular part is very important, because when the ERCP is done, the particular knowledge of the minor duodenal papilla, major duodenal papilla, then those folds of the mucous membrane, those are important because they will guide the person who is operating that endoscope. Okay. After that only the contrast media can be injected exactly into the major duodenal papilla so that it can go into the common bile duct and the pancreatic duct. Okay, that's why this particular part, the anatomy of this particular part is important. Okay, now here you can see a barium meal X-ray, okay, spatial radiographic investigation, where various parts of the duodenum can be seen. So this is the stomach, this is the pyloric part of the stomach. Okay, now always keep that in mind. The first part of the duodenum, okay, I have mentioned that in the first part of the duodenum, those circular folds are absent. Okay, it is starting from the second part mainly. Now, when you will give barium sulfate to the patient, in barium studies we are giving barium sulfate to the patient. When the patient is swallowing the barium sulfate, as it is traveling through the GIT, at that time the mucosal pattern of that particular structure can be seen. Okay, now from there we can differentiate spatially. So see this particular part, the mucosal pattern. Okay, see the mucosal pattern. As it is going to the other parts of the duodenum, see barium broken up by circular folds of the duodenum. Just see the appearance. Okay, it is normal anatomy. Okay, why it is appearing like this? Because of the circular folds which are present inside the duodenum. Okay, that's why the appearance is like this. Next, when we will discuss about the large intestine, at that time we will know what is the appearance in case of large intestine. Okay, so because of this mucosal pattern, the appearance is different. Next, this is very important. This is also called as duodenal cap. Now, what is this duodenal cap? The first part of the duodenum. Okay, we have discussed the first part of the duodenum. Now, due to the unique geometry of the first part of the duodenum, when the barium will flow through the first part of the duodenum, it will appear a cap-like structure. Okay, which is normal. If duodenal cap is appearing in the X-ray image, that means it is normal. Now, there are some cases where duodenal ulcer is present. In that case, the particular cap-shaped appearance will not be there. From that point of view, the person can identify, the doctor can identify that yes, duodenal ulcer is there. Okay, so that is all about the internal structure and the X-ray image of the duodenum showing the various part. And whenever the barium is given, I have shown you what is the flow of the barium. Okay, because of the circular folds, the broken lines can be seen, and that is only because of the circular folds. Okay, next, blood supply of the duodenum. Now, the blood supply of the duodenum is very important because the first part of the duodenum, okay, the first part of the duodenum is prone to ulceration. Okay, because of that. Okay, that means the reasons which are there, among them one important reason is of the blood supply. Okay, now if you see the duodenum, it is developing both from foregut and midgut. Okay, that's why it is supplied by celiac trunk as well as from the branches of superior mesenteric artery also. Okay, when you will study the development of alimentary canal, at that time you will come to know that the alimentary canal is derived mainly from foregut, midgut and hindgut. Okay, so all the structures which are derived from foregut, midgut and hindgut, okay, they are supplied by a particular artery. For foregut it is celiac trunk, for midgut it is superior mesenteric artery, and for hindgut it is inferior mesenteric artery. Okay, though duodenum is partly formed from foregut and partly from the midgut, that's why it is supplied by the arteries of both foregut as well as midgut. Okay, that means it is supplied by some branches of the celiac trunk and some branches of the superior mesenteric artery. So duodenum grows from foregut and the lower half from the midgut. That's why it is supplied by celiac trunk, which is the artery of the foregut, and lower half from the superior mesenteric artery, that is the artery of the midgut. Okay. Next, mainly two arteries are there which are supplying blood to the duodenum. What are these two arteries? It is the superior pancreatic or duodenal artery and inferior pancreatic or duodenal artery. Now, in case of superior pancreatico-duodenal artery, it is a branch of gastro-duodenal artery, which is a branch of hepatic artery, and it comes from the celiac trunk. Okay. Next, the inferior pancreatico-duodenal artery, which is a branch of superior mesenteric artery. Okay, so these are the main two arteries which are supplying blood to the duodenum. Now, here you have to understand one thing. You have seen the second part of the duodenum. Okay, now just around the second part of the duodenum, the concavity of the second part of the duodenum, what happens? These two arteries, superior and inferior pancreatico-duodenal artery, they will anastomose with each other. Before anastomosing, they used to give two branches, anterior branch and posterior branch. This anterior and posterior branch will anastomose with each other, okay, around the concavity of the second part of the duodenum. Okay, after that, they will form the arterial arcades. Now, anyone, have you heard about arterial arcades? Arterial arcades, anyone, have you heard about the arterial arcades? Have you heard about arterial arcades and vasa recta? Okay. So, those who have not studied or not heard about the arterial arcades, okay, let me show you. Now, please see the diagram carefully. Okay. Now, which part is this? This is the which part of the duodenum? Which part of the duodenum is this? Second part of the duodenum. Wake up. This is the second part of the duodenum. From last week onwards, I am shouting about the parts of the duodenum. This is the second part of the duodenum. As you can see, the superior pancreatico-duodenal artery. Okay, and from here you are getting the inferior pancreatico-duodenal artery. Okay. This is the inferior pancreatico-duodenal artery, this is the superior pancreatico-duodenal artery. Okay. Now, these two arteries, as I said, they will give two branches over here into the concavity of the duodenum. That is the anterior branch and posterior branch. Okay. Now, this anterior and posterior branch, what will happen? They will anastomose with each other. As you can see, they are anastomosing with each other. Once they are anastomosing with each other, from that anastomosis, first we are getting the arterial arcades. Okay, or also you can say arch-like arteries, arterial arcades. From that arterial arcades, the straight vessels which are coming out, that is called as vasa recta. That is called as vasa recta. Okay, I hope you can see these are the straight branches. Can you see? Now these straight branches, these are called as vasa recta. That will go and supply the wall of the artery. That will go and supply the wall of the duodenum. Okay. Now why it is important? After duodenum, you have to study about the jejunum and ileum, which are the parts of small intestine. Okay, at that time, the mesentery which is present, okay, the mesentery which is present or which is attached to the wall of the jejunum and ileum, at that time you will see that the blood supply to coils of jejunum and ileum in that arterial arcades, vasa recta, all those things are there. But the way they are branching, that is different. And based on that, you have to identify or you have to differentiate the coils of jejunum and ileum. Okay, suppose you have seen the coils of intestine in the cadaver. Coils of intestine you have seen in the cadaver. Now suppose I have taken out the coils of the intestine. I have removed the duodenum. Okay, and then I have given it to you. Now identify which is jejunum, which is ileum. I have taken out from the body, okay, from the cadaver. How will identify? Without cutting, without taking any LS or TS. It will look same because no clear-cut demarcations are there between the coils of jejunum and ileum. Okay, at that time, based on the external features, how you have to identify? You have to identify on the pattern of the blood supply, which is present, which can be seen on the mesentery. So you have to take it like this, okay, in front of any light source, okay, you will see the pattern of the blood supply, okay, how the arterial arcades, okay, how the vasa recta are there, okay. From there, you have to identify. That's why the arterial arcades, vasa recta are important, okay. So in case of blood supply of the duodenum, as I said, two main sources are there. What are they? Superior, inferior pancreatico-duodenal artery. Okay. Now, as you can see, they are giving two branches, anterior, posterior, and they are anastomosing on the concavity of the second part of the duodenum. From there, arterial arcades are arising. From arterial arcades, we are getting straight branches, which are called as vasa recta, that will go and supply the wall of the most of the duodenum. Okay, along with that, this particular anastomotic channels, they are also supplying head of the pancreas. That's why it is called pancreatico-duodenal artery. That means it is supplying duodenum also, and it is supplying some part of the pancreas, not entire pancreas. Next, additionally, the head of the pancreas. So, additionally, the first part of the duodenum is getting blood supply. Means additional branches are there which are supplying blood to the first part of the duodenum. Okay. Now, that is the supraduodenal part of the Wilkie. Okay, that is a branch of gastroduodenal artery. Okay, comes from the celiac trunk, supplies the anterosuperior and posterior surface of the first part of the duodenum. Okay, so these are some blood vessels, additional blood supply for the first part of the duodenum. First is the supraduodenal artery of Wilkie. Next, you can see the first part receives additional blood supply from retroduodenal branch of the gastroduodenal artery, some branches from hepatic artery, and some branches from right gastroepiploic artery. Okay. Now, here is a clinical significance. Now, what is this clinical significance? Have you heard about end arteries? I hope you have heard about end arteries. Okay. So, mostly the first part is supplied by end arteries. In other parts, I have told you the anastomotic channel is there. But for the first part, directly those branches will go and supply the first part. That's why they are end arteries. That means any blockage or any damage to the blood vessel, that first part will not get blood supply. That is also a reason why ulceration is common in the first part of the duodenum. Okay. Other causes include whenever the acidic food comes from the stomach, directly it is going into the first part of the duodenum. Okay, that's why the chances of getting ulceration in the first part is also common. Okay, so here you can see the additional blood supply which is given to the first part of the duodenum. As you can see, this is the supraduodenal artery of Wilkie. Then you can see some branches from the hepatic artery, okay, and some branches from the right gastroepiploic artery. And as you can see, all these are the end arteries. Okay, they are arising, they are supplying directly. They don't have any anastomotic channels. Okay. So from here you can expect the question from applied anatomy, that why the first part of the duodenum is prone to duodenal ulcer. Okay, nerve supply of the duodenum. Okay, the nerve supply of the duodenum, as you have noticed that previously also we have discussed, in case of nerve supply, two sources are there. It is sympathetic, parasympathetic, right? Similarly, in case of duodenum, sympathetic and parasympathetic is there. Okay, two divisions are there, sympathetic as well as parasympathetic. If you see the sympathetic, they are coming from T6 to T9 segment of the spinal cord. Okay, T6 to T9 segment of the spinal cord, and parasympathetic, it is coming from the vagus. Okay, in case of nerve supply of duodenum, two sources are there. What are these two sources? Sympathetic and parasympathetic. As I said, sympathetic is coming from T6 to T9 section of the spinal cord. Previously, I hope you remember, I have shown you one diagram of the cut section of spinal cord, right? In that, you have seen that it is having mainly three horns. Ventral horn is there, lateral horn is there, and dorsal horn is there. Okay, and I have shown you how the nerves are coming out, especially the sympathetic one. And for parasympathetic, they are coming from vagus. Okay, so here sympathetic, they are coming from T6 to T9 segment of the spinal cord, and parasympathetic from both the vagi. After that, they will join the celiac plexus. Okay, so celiac plexus is one of the largest autonomic plexuses of the posterior abdominal wall. Okay, which is present around the celiac trunk. Okay, so abdominal aorta, from where the celiac trunk is coming out, around the celiac trunk, a autonomic nerve plexus is formed. That is called the celiac plexus, and it is one of the largest autonomic plexuses situated in the posterior abdominal wall. Okay. Now from there, the branches which will appear. So first the plexus will be formed from, and it is a mixed plexus where both sympathetic, parasympathetic components are there. From after that, the nerves which will arise, they will go and supply the particular organ. Okay. Now in case of duodenum, the plexuses run along the arteries which are supplying. In most of the cases, you will see that along with the blood vessel, the nerves are also traveling to go and supply the organ. Here also same thing is happening. Now the parasympathetic division causes vasodilatation, increase in the secretion, promotes motility of small intestine. Okay, these are the functions of the parasympathetic division. Okay, so it will increase the motility, it will cause vasodilatation, increase secretion. Now what will be the sympathetic? It will be the opposite one, the sympathetic. Okay. Decrease in the secretion, that means inhibit the secretion, okay, inhibits the motility. That is the function of the parasympathetic division. Okay, so sympathetic, parasympathetic, as I said, always they are opposite to each other. Okay, next, so that is all about the gross structure. Next, we'll start with the applied anatomy of the duodenum. Now, in the applied anatomy of the duodenum, first we'll see about the duodenal recesses. Okay, duodenal recesses. Though you have studied the peritoneum, peritoneal cavity, peritoneal folds, okay, have you heard about these duodenal recesses? Anyone? Have you heard about the duodenal recesses? Now, duodenal recesses are nothing but the pockets of peritoneal cavity. Okay, these are the pockets, or you can say extension of the peritoneal cavity around the duodenum. Okay, so the duodenum which is there, around the duodenum, the peritoneal cavity which is there, from that part the extension of the peritoneal cavity are present. Okay, so for example, supraduodenal recess is there, or also called as superior duodenal recess, then paraduodenal recess, okay, retroduodenal recess and inferior duodenal recess. So these are the different recesses which are present around the duodenum. Okay, so in applied anatomy, first the duodenal recesses. So these are the small pockets or fossa of the peritoneal cavity, okay, bounded by the folds of peritoneum, extension of the peritoneal cavity, and they are bound by the peritoneum itself. Okay, now here you can see different recesses are the superior duodenal recess, this is the inferior duodenal recess, these are the paraduodenal recesses, and this is the retroduodenal recess. Okay, at different areas associated with the duodenum, extension of the peritoneal cavity. These are the duodenal recesses. Okay, now what is the importance of the duodenal recess? Sometimes the coils of the small intestine enter into these recesses. Okay, and these are called as internal hernia, and they can get strangulated. Okay, so those pockets which are there, sometimes the coils of the intestine can herniate into those pockets, okay, into the recesses, and these are called as internal hernia, and after that they can get strangulated. Okay, next, duodenal diverticulum. Okay, so duodenal diverticulum is nothing but the outpouching from the wall of the duodenum. Okay, so the wall of the duodenum is there. From there, see the diagram. Okay, so in case of duodenal diverticulum, what happens? The wall of the duodenum, from there a outpouching which takes place. Now it occurs mainly whenever weakness are there in the wall of the duodenum, or suppose the area from which blood vessel is entering the duodenum. These are the areas in which the duodenal diverticulum takes place. Okay. Now, if you see the location of the duodenal diverticulum, most commonly it is occurring at the second part of the duodenum. Okay, occurring at the second part of the duodenum. Now, two types of diverticulum are there, as you can see in the image: true and false diverticulum. Okay. Now, in case of true diverticulum, all the layers, for example, mucosa, submucosa, muscularis, serosa, all the layers are present. Okay, and in case of false diverticulum, only the mucosal layer will be present. That is the difference between true and false diverticulum. Okay. Now, it is also classified as acquired and congenital. Most of the cases it is asymptomatic. Okay, most of the cases it is asymptomatic, and if diverticulum is there, it can be diagnosed easily with the help of endoscopy or with the help of barium studies, which you can see. Okay, so see, this is the normal appearance. If diverticulum is there, you can see the appearance. Okay, very easy to diagnose. Now, in some cases, a rupture of the diverticulum takes place, and that is very difficult to treat. Okay, in some cases, the rupture is taking place. So that is the intestinal diverticulum. Next, there are some specific applied importance related to the various part of the duodenum. Okay. Now, for example, first part, as I said, it is prone to peptic ulcer. Why? First part, it is prone to peptic ulcer. since it is supplied by the series of end arteries, which already we have discussed. Next, sometimes the gastroduodenal artery passing behind the first part is eroded, because once the ulceration is taking place, okay, and that time the erosion will be there, okay, and that can damage the blood vessel which is situated behind the first part of the duodenum. At that time there will be severe bleeding. Next, second part is mostly protected, okay. Second part is mostly protected part. Now in the second part we have seen the ducts which are entering inside the duodenum, okay, that is the main pancreatic duct, then common bile duct, okay. Now sometimes the bile stone which is present, if the bile stone is present in the common bile duct, at that time there will be obstruction, okay, biliary obstruction, okay. Now when the biliary obstruction is there, and if it is near the papilla, then obstructive case of jaundice will take place. Next, annular type of head of the pancreas is there, okay. It is a type of congenital anomaly of the pancreas which will encircle the duodenum. In such cases, there is duodenal obstruction. Okay, annular pancreas is a congenital anomaly. Okay, now that will encircle the second part of the duodenum, and that can cause obstruction of the duodenum. Next, in third part, it is most vulnerable by external injury, because it can be compressed between the vertebral column and violence through the anterior abdominal wall. Okay, that means a blunt trauma in the anterior abdominal wall, okay, can cause compression into the third part of the duodenum, okay, and it can also be compressed by the pressure given by superior mesenteric artery, okay. So these are some important applied significance of the various part of the duodenum. Now last time I have told you that if ulceration is there in the first part of the duodenum, at that time what will happen? If you take the barium studies, that means barium X-ray, if it is done, then you can see the appearance of the duodenal cap. Okay, so this is the first part of the duodenum. When a person is not having any ulcer, when the duodenum is normal, at that time after giving barium, what will be the appearance? The appearance will just like a cap. Okay, the person wearing cap, that type of appearance will be there. Okay, now if that type of appearance is not there, if it is distorted, that means duodenal ulcer is there. Okay, and that you can see in this particular barium image. Okay, so this is how it can be diagnosed very easily. If a person is having duodenal ulcer, and as I said, ulceration in case of duodenum is very common. In which part? In the first part of the duodenum. Okay, and after that, when the barium studies are done, for example, barium meal is there, barium meal follow through. Okay, at that time, this kind of appearance will be there. Okay, next here you can see pancreatic cancer. If there is any cancer malignancy of the head of the pancreas, at that time you can see it is obstructing the common bile duct. That also we have discussed in the last class. Okay, you can see it is obstructing the common bile duct. As a result, what will happen? There will be obstructive jaundice. Okay, because the bile will unable to flow through the common bile duct. Okay, and that will cause the obstructive jaundice. Okay, so that is all about the applied importance of duodenum. Okay, so today we have seen the internal structure of the duodenum, the mucosal pattern of the duodenum, then blood supply, nerve supply, and applied importance of the duodenum. Okay, that is all about the duodenum. Okay, next topic is about the pancreas. Anyone, have you seen the pancreas in the cadaver? Have you seen the pancreas? Not yet. Okay, no problem. I think today or tomorrow you will see the pancreas. Okay, so let's discuss about the pancreas. So if you see the pancreas, okay, it is soft, finely lobulated and elongated exoendocrine organ. Okay, if you see the pancreas, it is soft, lobulated, okay, and totally fleshy appearance. Exo and endocrine gland present at the posterior abdominal wall. Okay, now why it is exoendocrine? That means it is having both exocrine and endocrine function. Okay, Now you know that exocrine function means it will secrete pancreatic juice, and endocrine means various hormones are secreted. Among them, the most important one is the insulin. Okay. Now the pancreas, the meaning is pan means all, creas means fleshy. That means all fleshy organ. Okay. Next, pancreatic juice, which is secreted by the exocrine part. What is the main function? It will help in lipid, carbohydrate, and protein digestion. Okay. And the hormones which are secreted maintains the glucose homeostasis. Very important. Okay. Now, what do you think? How many parts are there in the pancreas? And what is the location of the pancreas? Now, if you see, the pancreas is situated almost horizontally into the in the posterior abdominal wall. Okay, it is situated horizontally in the posterior abdominal wall. Okay, where in the epigastric and left hypochondriac region. Epigastric and left hypochondriac region. These are the areas where the pancreas is situated, and that also it is placed horizontally. Now, if you see the pancreas, though it is placed horizontally, it is crossing the posterior abdominal wall obliquely into the concavity of the duodenum, okay, and then extend into the hilum of the spleen, and it is situated at the level of T12 to L3 lumbar vertebra. Okay, that means the concavity of the duodenum, okay, where the head of the pancreas is present. From here, it is extending horizontally and then going toward on the left side. It also up to the hilum of the spleen. I know you have studied the spleen. Okay, so that is the extent, horizontal extent of the pancreas. At which vertebral level? T12 to L3 vertebral level. Now the greater part is retroperitoneal. Okay, that means most of the part of the pancreas is retroperitoneal. That means it is situated behind the peritoneum. Now the left extremity is lying into the linorenal ligament. Now can anyone tell me the applied importance of this linorenal ligament? Do you know the applied importance of the linorenal ligament related to spleen? So, yeah, linorenal ligament which is there, okay. In linorenal ligament, splenic vessel as well as tail of the pancreas is present, okay. Next, though you have studied the spleen, I hope you have heard about splenectomy. When the splenectomy is done, at that time, care should be taken so that the contents of the linorenal ligament should not be damaged. Okay, because it is attached to the spleen. Now, if it is damaged, then what will happen? The tail of the pancreas will get damaged. Okay, most of the islets, which is the endocrine part of the pancreas, is present inside the islets. So, if the islet is damaged, okay, immediately patient will suffer from diabetes mellitus. That's why care should be taken, and that is the most important clinical significance of the linorenal ligament. Okay, so here you can see the location of the pancreas. So in the from the concavity of the second part of the duodenum up to the hilum of the spleen, the vertebral level is T12 to L3. Okay, now here I have added one CT scan image. Okay, as you know, I am showing you different types of radiological images. Okay, so here you can see it is a CT scan image, cross section, axial section of the abdomen, where you can see these are the various parts of the pancreas. See, these are the various parts of the pancreas. This is how the pancreas look like whenever a CT scan is taken. Okay, now size and shape. So it is J-shaped or retort shaped. Okay, the length is approximately 50 to 20 centimeter. Broad 2.5 to 3.8 centimeter broad. Thickness is approximately 1.2 to 1.8 centimeter. Weight is approximately 80 to 90 gram. Okay, these are the dimensions of the pancreas. Now, division, as you know, the pancreas is divided into various parts. That means if you go from right to left, then it is divided into head, neck, body, and tail. And head is having one small process that is called as uncinate process. Okay, here you can see the parts of the pancreas. Okay, so from right to left, if you go, what are the division? First of all, head is there. Okay, enlarged part, and having one small process that is called as uncinate process. Next, the constricted part is the neck. After that, body and tail. Okay, so these are the various parts of the pancreas. Okay, now along with the various parts of the pancreas, you have to know that these particular parts, they are having some surfaces and borders. Okay, these particular parts, they are having surfaces and borders, and each and every surface and borders, they are having some important relation. Okay, now though pancreas is a retroperitoneal organ, that's why we will not discuss about any peritoneal relation. It is retroperitoneal. In the last class, I have told you, whenever any abdominal organ, if you are studying about the relation, it is divided into two parts, that is the peritoneal relation and visceral relation, right? In case of retroperitoneal organ, we don't have to study about the peritoneal relation, means no direct attachment of the peritoneal folds are there. But in case of visceral relation, it depends on the surfaces and borders of the organ. Okay, now if you take the example of the head, okay, head is having three borders are there. Okay, here will be the upper border, superior border, here will be the inferior border, and here will be the right lateral border of the head. Okay, next two surfaces are there. Okay, here you can see this is the anterior surface, and behind that will be the posterior surface. Okay, so like this, the surfaces and borders which are there, according to that you have to know about the relation. Okay, same in case of neck also, the anterior surface is there, behind posterior surface. Okay, then if you see the body of the pancreas, okay, three borders and three surfaces are there. Okay, if you see the body of the pancreas, it is prismoid shape, and if you take the cut section, if you take the TS, then it is triangular shape. Okay, and it is having three borders, three surfaces. So that thing you have to understand, or else you have to by heart all the surfaces, all the relation. Okay. Now in case of body of the pancreas, so this will be the upper border. Okay, this will be the upper border. This is the here another border is present, that is called the anterior border, and here you will be getting the inferior one. Okay, so like this, different borders and different surfaces are there, and based on that, the relations are present. Okay, so head of the pancreas, as I said, it is having three borders, superior border, inferior border, and right lateral border, and two surfaces are there. That is anterior surface, posterior surface. And along with that, there is a small extension which is project from the lower and left part of the head, that is called the uncinate process. Okay. Now here you can see the first, this is the head of the pancreas. So here you will be getting the upper border, here you will be getting the lower border, this is the right lateral border. Okay. Now if you see the relation, the lower border, it is related to the third part, upper one will be related to the first part, this is related to the second part of the duodenum. Along with that, you will also get the superior inferior pancreatic or duodenal artery, the anastomosis. Okay. Next, here you can see this is the anterior surface, and behind will be the posterior surface. Okay. Now on the anterior surface, the relation mainly the transverse column, which is coming anteriorly. Okay, and this is the posterior relation of the head of the pancreas. That means the posterior surface is related to the you can see bile duct is there. Then renal veins are there, right and left renal vein, inferior vena cava, left crus of the diaphragm. Okay, and some part of the abdominal aorta. Okay, which, and these structures are situated posterior to the head of the pancreas. Okay, so here also, just like the duodenum, for each and every part, in order to understand the relation, first you have to know about the surfaces and borders, followed by whenever you are going to the dissection, just see the structures which are present all around. Okay, then you can visualize the thing, what is present anterior, what is present posteriorly, what are present laterally. Okay. Now the uncinate process which is there anteriorly to the superior mesenteric vessel, posteriorly to the abdominal aorta. Okay, these are the structures which are present on the anterior and posterior aspect of the uncinate process. Next is the neck. Okay, next is the neck of the duodenum. Now if you see the neck, it is the constricted part which connects the head to the body. So always we know that neck will be the constricted part. It is connecting the head and the neck body of the pancreas. Okay, approximately 2.5 centimeter long. And if you see the direction, it is directed forward, upward, and to the left. Forward, upward, and to the left. Okay, forward, upward, and to the left. It is going to the left. Okay, so that is the direction of the neck of the pancreas. Okay, now in case of pancreas, following external features are there. So only two surfaces and two borders are present. As you can see, two surfaces, anterior and posterior surface, two borders, upper and lower border. External features in case of the neck of the pancreas, two surfaces and two borders are there. Okay, so two surfaces, upper surface, lower surface, also to the superior border, inferior border. Okay, as you can see, two borders are there, upper and lower border, and two surfaces, anterior surface and posterior surface. Okay, for the neck of the pancreas. Now these are also having important relation. Okay, now if you see the anterior surface, it is related to the pylorus of the stomach. Next, posterior surface is related to the commencement of the portal vein. Now, while discussing about the formation of the portal vein, I have shown you that how the portal vein is formed. Union of the superior mesenteric vein and the splenic vein behind the neck of the pancreas. Okay, the portal vein is formed. So directly you can write the formation of the portal vein, okay, as a relation for the posterior surface of the neck of the pancreas. Next, the upper border which is there, that will be related to the first part of the duodenum, and the lower border is related to the transverse mesocolon. Now in this diagram you can see the relation. Okay, so this is the relation for the anterior surface where the pylorus of the stomach comes. Okay, next this is for the posterior one. Okay, now in the posterior surface of the neck, what is formed? You can see the formation of the portal vein is taking place, splenic vein and superior mesenteric vein. Okay, now in this, so these are the cut sections. Now here you can see these are the relations which are for the posterior surface of the neck of the pancreas. Okay, to see the structures, mainly the formation of the portal vein. Now here on the anterior aspect, okay, mainly we are getting the transverse mesocolon. Okay, the attachment of the transverse mesocolon. So like this, the relations have to be studied. Next, for the inferior one, you can see this is the third part of the duodenum. Okay, next is the body of the pancreas. So as I said, the body of the pancreas is elongated. It is extending from the neck to the tail. Okay, and it is prismoid shaped. If you take the cut section, what will be the appearance? The appearance will be triangular in shape. Okay, so regarding the body of the pancreas, okay, the border surfaces, the relation that we will discuss in the next class. Thank you.